Much, Dr. Dhairyashil. It's a pleasure to be here, Dr. Prasad and Dr. Govind. This is something which I really thought about when I was making the slides. And I realized that we have made amazing breakthroughs in the last 5 years, which I focused on. Could you please share my slides? I'll start my timer now. Could you share my slides, please? So basically, I'm going to focus on various aspects of breast cancer, including, could you share my slides, please? Do you mind if I share my screen?
Nirav, can we have a slides or can Madam
just
share the
1
slide?
minute? We are putting
Sir,
up the slides.
just a second. I'll share the slide. Just a second.
So if you make me the host, I can actually.
There are issues, Madam. If he doesn't do it, we'll give it to you, ma'am.
Okay, so let me just try, and I have closed
Give
it.
me as 1 minute, ma'am. If it's not there, we'll give it to rights to you.
Okay, sorry. Okay, let me. It's open. So I thought hybrid platform is, using two platforms. I didn't realize it's live and virtual. So, okay. So thank you, Dr. Sawant. So please go on to the next slide. So breakthrough for me is something that has changed clinical practice globally and is relevant to us in India. And the most important is important for patients' quality of life and overall survival or outcomes, and whether we are able to de-escalate treatments to make them smarter and kinder. And some of the practices have made themselves in the clinic despite no robust evidence. So next slide, I will just present the study on prevention that was done in Spain for lifestyle patterns. Just a quick reminder that, having supper early and a long interval between supper and sleep reduces the risk of developing breast cancer by 20%. So I think this was very quite a well-designed population-based study done in Spain. Next slide. A brief word about surgery and diagnostics and radiotherapy as well, because we know my surgical colleagues tell me the use of MRI scans has made it into clinical practice and is quite a big breakthrough in planning breast conserving surgery. Oncoplastic work, yes, we do not have robust randomized evidence, but if you ask patients, the improved cosmetic outcome has definitely improved the quality of lives, and there are a few studies on that. There is de-escalation of axilla management, so we are decreasing, hopefully, the incidence of lymphedema by using clipping, also by sparing the axilla if the patients had a node-negative axilla before the start of neoadjuvant chemotherapy. The other thing, probably not in diagnostic, is the use of liquid biopsies or circulating tumor DNA and next generation sequencing, which is driving treatment in advanced setting. Beyond first line and second line, that remains a challenge as far as cost is concerned. There are quite a few homegrown assays as well, but again, we need a lot of prospective data and publications as well, and validation on survival outcomes from them. Next slide. As far as radiotherapy is concerned, we are going less duration. The START has made 3-week as standard of care, the hypofractionated schedules, and fast forward, yes, there is a lot of debate about that. Probably not to be used in younger women less than 40 years of age. We had this discussion at the ESMO Breast Cancer in Young Women meeting a couple of weeks ago. But I think this is something which is food for thought, especially for some of our patients who are coming from long distances to have adjuvant radiotherapy. Use of deep inspiration breath holding has reduced the doses that are delivered to the heart. And for left-sided breast cancers, again, is practice changing. Next slide. So, as far as supportive care is concerned, scalp cooling, fantastic data from Tata Hospital by Jyoti, and also quite some data from the Western population as well. It is here to stay, and I think we must strive to have scalp cooling in most of the oncology daycares which treat breast cancer. Bisphosphonates for 3 years add another 2% to the overall survival benefit. And yes, we used to give it for 5 years earlier, but now we have reduced it to 3 years, zoledronic acid 6 monthly, which I think is a breakthrough. It helps with the bone health as well because we are giving endocrine treatment for longer. Geriatric assessments to reduce treatment toxicity, which Vikas talked about. Again, we have started using and is a major breakthrough. We are talking about it as well. Survivorship issues, cardio-oncology is upcoming, is again another exciting field. Oncofertility for me, I think for younger patients is very exciting with the use of pre-implantation genetic diagnosis because this is something which is now we can offer to our patients in India. Next slide, please. As far as chemotherapy is concerned, omission of 5-FU, short course trastuzumab, I will talk about some of the studies which are relevant to us. But there are some other studies on neoadjuvant use of dual anti-HER2 therapy, adjuvant use, and use of neratinib, which I will not discuss because most of our patients are not able to afford it. But the evidence is there for disease-free survival benefit. There is no overall survival benefit with any of these. Next slide, please. We are using more and more of neoadjuvant treatment. Next and next, please. To increase the PATH-CR rates, but we know that the next slide, that it does not actually translate into a better overall survival. Next slide, please. So the use of platinum in triple negative breast cancer and the use of dual anti-HER2 treatment, especially in patients who are ER negative, has increased the PATH-CR rates up to 50 to 60%, so that now we are actually doing clinical trials to omit surgery in some of these patients by the use of MRI and vacuum biopsies of the tumor bed, which is being led by the MD Anderson also and also by the NHS. Next slide, please. Next slide. So the thing that which is most relevant to all of us is not using 5-FU in the clinic. This trial randomized patients to AC versus FEC100. Next slide, please. And basically showed that you can see the curves literally on top of each other for disease-free survival and overall survival. So I think 5-FU just adds to the toxicity. I have not used 5-FU in my clinic in breast cancer patients since 2015. Next slide, please. So this was in node negative patients, even in node positive patients. Next slide, please. The GYM2 study showed that that you can see the top curves that the survival is absolutely similar. The bottom curves are with dose dense, which show that dose dense is better than 3 weekly. Next slide, please. So again, neoadjuvant treatment, creating an opportunity to modify treatment to optimize outcomes has been something which has changed our clinical practice. With the next slide, with the use of adjuvant capecitabine. Next, the Japanese study, we were waiting for the publication to come for quite a long time. Basically, patients who do not have a complete path response post anthracycline taxane based treatment, even platinum based treatment, after radiation receive capecitabine. And again, this has been practice changing, especially in triple negative breast cancer, where there is a significant improvement in overall survival and disease-free survival. Next slide, please. Also in HER2 positive, next slide, please. The Catherine study has shown that there was an improvement in disease-free survival. We can discuss the complexities down the line. As far as hormone therapy is concerned, I think I will not discuss all the trials, but we have extended the duration of adjuvant endocrine treatment, both in premenopausal and postmenopausal ladies for 10 years. Addition of ovarian suppression for premenopausal women is something that we know has definitely improved outcomes. What we are trying to do is, and I think Meredith Regan has done some fantastic work on this, to see whether we can avoid giving ovarian suppression to some of the younger ladies. And I think there is some data to show that this should be considered for premenopausal patients with high risk breast cancer. The other data I found quite exciting was the use of 5 milligram of tamoxifen in DCIS, which I will discuss, and the POETIC study led by one of my mentors, Professor Ian Smith, I remember recruiting patients into this study, and it was not difficult to convince patients to have a baseline biopsy, which all patients do, and then to have a repeat biopsy at 2 weeks. When we were designing the study, I was part of the group. I remember the biggest concern was that the patients will not participate having a biopsy 2 weeks later. Pharmaco Prevention, which used to be called chemo prevention for women at high risk of breast cancer with the use of tamoxifen, I think is something, again, with the use of chemo prevention or pharmaco prevention clinics, which is coming, is being utilized more. I think the evidence was there from before. Next slide, please. So, low-dose tamoxifen in DCIS, again, this fantastic trial shows that there is a risk in recurrence for breast cancer and also reduced risk of contralateral breast cancers. Next slide, please. Next slide. Next slide. Please complete the slide. So basically, this study showed that low-dose tamoxifen, 5 milligram, actually halves the recurrence of breast DCIS. And so we know that 5 milligram tablet is not available, but given the evidence, I think tamoxifen 10 milligram every day, we can safely reassure our patients who are struggling with tamoxifen with headaches and severe symptoms is applicable in clinical practice, but definitely for DCIS and some of our breast cancer patients as well, because you can see that there is a huge preventive potential with decreased contralateral breast cancer by 75%. Next slide, please. The Poetic study, again, the key take-home message for me is that the ladies who start with a Ki 67 less than 10% and it remains 10%, the 5-year risk of recurrence is less than 5%. Next slide, please. And so I think early changes in Ki 67 are associated with the 5-year time to recurrence. The previous studies by Mitch Dowsett have also shown that. A clear drop, I think, in Ki 67 to less than 10% after AI can help us make the final decision, maybe to forego chemotherapy on the basis of other prognostic information that we have, that the patient is HER2 negative. Next slide, please. In metastatic breast cancer, again, so much data in the last 5 years. I will just mention some and elaborate on a couple, actually. I have not put immunotherapy here because, again, I'm very happy to discuss this because I do not see that as a breakthrough at all. Trastuzumab deruxtecan, third line for HER2 positive patients. Tucatinib, trastuzumab, capecitabine, again, exciting data. It's not available in India. Neratinib, cape. CDK4/6 inhibitors, I think, is the most exciting space. And also in PIK3CA mutated advanced breast cancer, alpelisib, again, very expensive. Olaparib in germline BRCA mutations has made it into the clinics. There was a disease-free survival benefit, but again, there were a lot of downsides to the study, not including platinum. We can discuss that. Sacituzumab govitecan in metastatic triple-negative breast cancer, where we do not have enough options, was quite exciting in third line. Next slide. So again, for me, the most important study was this phase 2 study, which has changed practice. Next slide, please, where patients with a tumor less than 3 centimeter, HER2 positive, received 3 months of paclitaxel rather than 6 months of chemotherapy and trastuzumab for node negative HER2 positive. Very rarely we see these kind of survival curves where the disease-free and overall survival is more than 95%. Next slide, please. So I think this is practice changing, and with the shorter duration of trastuzumab with the Persephone trial, I think you can reduce the duration of trastuzumab as well. Again, excellent meta-analysis published by Seema Gulia from Tata Hospital, which makes us think maybe we could give 3 months of trastuzumab as well. First-line CDK4/6 inhibitors, again, ESMO MCBS scale, I find it quite good. There is robust evidence to use CDK4/6 inhibitors along with AI therapy in pre- and post-menopausal as first-line treatment. Next slide, please. In second-line treatment as well, there is robust data. Next slide, please, with the use of fulvestrant. So I think to conclude, I think this is the most important slide for me when you look at breakthroughs is for a patient, what matters is, will I live longer? Will I have good quality of life, and the cost, which is uppermost in the patient's mind. So I think I mean, just listening to earlier presentations, it's so exciting to see the newer generation thinking about these things, because I think we as an oncology community have to design trials which are smarter, which are effective, and which are relevant not only for our patients, but actually they will change practice globally, because I think we have to lead the way here in this. And so all of these are very, very important. But for me, overall survival and quality of life is the most important. Next slide, please. And to end the talk, I would say that if patient reported outcome measures were a drug, I think we would all be using it right from day one in our clinics. So I would encourage all of you that, patients are at the heart of improving outcomes. There is an overall survival difference if you use PROMs and PREMs in your clinic, patient reported experience measures. And, it is so easy to do. I piloted this when I was in London through an app, and it is very useful, because it maintains compliance of treatment as well, and also improves patients' quality of life while they are going for treatment, because they know that the red flags will be seen by somebody and acted upon. Thank you. Sorry, yes, one more slide. Again, avoiding surgery, I've already talked about, and I think the future is, for me, I want to look at TILs. If a patient has high TILs, yes, it's important in triple negative breast cancer, but I also want to see. I've got 40 seconds, whether we can avoid anti-HER2 therapy in those patients. So we have to try and see in which patients, because there are some patients who are long-term survivors. I have quite a few who never had trastuzumab treatment. And for me, the most exciting is 5 milligram of tamoxifen and using Ki 67 to maybe avoid post-op adjuvant chemotherapy. Thank you.